Thank you, Chairman. And at the outset, I would thank Dr. Sanjay Kumar and his team for the invite, and at the same time congratulate them for holding such a well-organized and excellent academic feast. To start with the topic, I will be showing few slides, introductory slides on liver diseases in pregnancy, followed by some real-life conditions in form of cases. So liver disease is a serious problem in pregnancy and poses a challenge both for gynecologists and hepatologists. Incidence around 3% may lead to various complications to mother, baby, or to both. Now, pregnancy as such is a warlike situation for mother because of sudden increase in metabolic needs of the mother as well as of baby. This in turn needs massive changes in physiology of mother to meet the demands of this condition. In form of these pregnant women, they develop hyperdynamic circulation. There is peripheral vascular dilatation, increased venous return to heart, increased stroke volume, enhanced cardiac output, and at the same time, liver also undergoes physiological changes. For example, portal flow can increase as much as up to 50% by second trimester. Now, what is the normal physiology in pregnancy? As we all know, they may have low albumin because of dilutional hypoalbuminemia. They may show low levels of hemoglobin. They may have raised alkaline phosphatase, but it should be always be below 2 times of the upper limit of the normal. They may have raised levels of alpha fetoprotein in normal pregnancy, but SGOT, SGPT and PT-INR should always be normal and should not be neglected, and you always have to dig in further regarding disturbances in these parameters. Now, we can classify these liver diseases like pregnancy-related liver diseases in form of hyperemesis gravidorum, intrahepatic cholestasis pregnancy, acute fatty liver, preeclampsia, eclampsia or HELP syndrome. This portion, as per discussion with Dr. Sanjay, this portion I will be skipping because this is too often discussed in various forums, and gynecologists, they can treat these conditions better than us. Regarding other causes, the pregnant women, they can have already coexisting liver disease in form of hepatitis B or C, or they may have maybe having cirrhosis and portal hypertension before they conceive. They may have autoimmune liver disease, Wilson's disease, or they may suffer from some coincident condition during pregnancy like acute viral hepatitis, which is the most common cause of liver illness in pregnant women. Apart from pregnancy related liver diseases, they may have biliary diseases in form of gallstones or primary biliary cholangitis or sclerotic cholangitis. They may have vascular diseases like Budd-Chiari syndrome, which they develop during pregnancy, or metabolic disorders. Now, basic pathophysiology of jaundice in pregnancy is either it is hepatocellular or cholestatic. Sometimes a combination of these is also seen. Now, if we approach a patient with cholestatic pattern, first of all, we should go for a sonography, and if it is negative for extrahepatic biliary obstruction, then we should consider either drug-induced injury, primary biliary cholangitis or PSC, and accordingly we advise them for antimitochondrial antibody, PBC specific antinuclear antibody, and still if we are suspecting that extrahepatic obstruction may be there despite a normal ultrasound, we may go for non-contrast MRCP. On the other hand, if there is a pattern of hepatocellular injury, viral hepatitis, autoimmune hepatitis, drug-induced injury, NASH or ASH, or metabolic disorders or vascular disorders are there in the differential diagnosis, and accordingly we ask for investigations like viral markers for hepatitis. We also have to rule out infections like herpes. So HSV DNA, CMV DNA, whenever we suspect the infections as a cause of deranged LFT, and we also ask for autoimmune markers, quantitative IgG, celiac antibody, if in case we are suspecting autoimmune hepatitis. Similarly, if we suspect Wilson's disease, we have to go for ceruloplasmin, slit lamp, 24-hour urine copper. Now starting with few interesting cases. This is a 28-year lady presents with 8 weeks of pregnancy. She has a primary HbA1c positive incidentally. Now all the guidelines like ASLD, EASL, NASL or APASL, they recommend that HbA1c screening is mandatory in each and every pregnancy. It has to be done. These investigations were asked for. LFT was essentially normal. Envelope antigen was negative. Antibody was positive. HBV DNA was not detectable. Should we ask for fibroscan in these patients? The answer is no, because in pregnancy fibroscan can give falsely high scores, so should be avoided in pregnancy as it may mislead us as far as diagnosis of fibrosis is concerned. So this patient was planned for a routine periodic monitoring of LFT 3 monthly, as we plan for other hepatitis B patients who are not pregnant, sonography periodically, and there was a plan for active and passive immunization of newborn within 12 hours of birth. What else we can do? Should we repeat DNA levels at 24 weeks? Because to begin with it was not detectable. The answer is yes. The guidelines suggest that it should be repeated at 24 weeks because pregnancy, it is a sort of immunotolerant state and it may promote viral replication during pregnancy. So DNA levels should be repeated at 24 weeks. In this patient, it came out to be 6 lakhs international units. Are antivirals needed? That is the second question. Yes, if viral load is more than 2 lakhs international units, antivirals are indicated according to all the guidelines. Now, which antiviral? So, tenofovir is the drug of choice in these cases. Firstly, because it is safer than other antivirals in pregnancy. It is a class B drug as compared to other antivirals which are class C. And at the same time, tenofovir is very potent drug and associated with less resistance. And the main purpose is to reduce incidence of mother to child transmission. Now this patient was put on Teno and she remained stable throughout, underwent normal delivery. Newborn was given immunoglobulin and active vaccination. Now in these conditions, if the baby is less than 2 kg, then the recommendation is for 4 doses of active vaccine, starting at birth, second at 6 weeks, followed by 2 more doses. So how long tenofovir should be given after delivery in this patient who was E antibody positive, and obviously she was in immune inactive phase. So different guidelines suggest that either you can stop at birth or you can continue it for 3 months. The basic rationale for continuation of this treatment after delivery is to reduce the flares which are seen more common in postpartum period. Now case number 2, a 32-year lady, known case of NASH-related cirrhosis, child class B, MELD score 12, endoscopy showed small varices 1 month back, and she presented with pregnancy, primary with 6 weeks of gestation. Bilirubin was a little high, 1.6, SGOT was 61. USG abdomen showed pregnancy of 6 weeks, coarse ecotexture of liver, portal vein was dilated, suggestive of portal hypertension. There was no ascites. She was put on high protein diet and was advised to avoid OTC drugs or indigenous drugs. And she was asked for anti-HAV IgG and HbS-AG. Reason? Because again, the guidelines suggest that all CLD patients should be vaccinated for hepatitis B and A. And vaccines of B and A are quite safe in pregnancy. So if a patient is already cirrhotic, conceives, she should be tested for HbS-AG and anti-HAV IgG. If negative, they should be vaccinated. Any need for upper GI endoscopy? Yes, it is recommended in second trimester. because in second trimester portal flow is very high and portal pressures can increase. And initially, to start with, even if the varices are small, in second trimester you can have large varices. So, endoscopic surveillance in second trimester is recommended. This patient presented with melena with drop in hemoglobin by 2 grams at 26 weeks. Upper GI was done, large esophageal varices with high risk signs were there. EBL was done. EBL is found to be safe in pregnancy. What about beta blockers? Beta blockers have got some side effects like intrauterine growth restriction, fetal bradycardia, or neonatal hypoglycemia. So, whether they should be given or not, the studies suggest that benefit outweighs the risks in these cases, and they should be given beta blockers. And only thing is, neonatals need close monitoring for bradycardia and neonatal hypoglycemia. Later she underwent LSCS because of fetal distress. Patient and baby did well in follow-up. Case number 3, 36-year woman presented with history of 2 gravidas and 1 early spontaneous abortion. The gestational age was 38. Chief complaint was itching only. There were no prodromal symptoms or abdominal pain. She was diagnosed as gestational diabetes in 24 weeks of gestation. Patient had a history of hypothyroidism. She was on Thyrox 50 microgram. Her routine biochemistry 1 month back was normal. She had a very high ALT, more than 1000, high AST. Bilirubin was very high, 16.8. Protein and albumin were normal. There was no evidence of hemolysis or thrombocytopenia. Viral markers for hepatitis A, E, and B and C were negative. Anti-nuclear antibody was weakly positive in 1:40 dilution. ASMA and anti-LKM1 were negative. Total IgG was 1.5 times above upper limit of normal. Anti-mitochondrial, anti-phospholipid antibodies were negative. Autoimmune hepatitis was suspected because of raised ANA and IgG, but since it was mildly weakly positive ANA, so there was not very strong ground for autoimmune hepatitis. She was started on ursodeoxycholic acid. She developed labor pains very next day and had normal delivery. After delivery, her LFT kept on deteriorating, and so liver biopsy was done on day 7, which came out to be suggestive of autoimmune hepatitis. In form of interface hepatitis, there was lymphoplasmacytic infiltrate, and along with that plasma cells denoted by perinuclear halos, so it was suggestive of autoimmune hepatitis. So she was put on steroids and azathioprine as an induction therapy, and we can see on day 14 the LFT started improving. Patient clinically also showed improvement, and LFT normalized at 4 weeks. This is another case. When reviewing literature for this presentation, I came across interesting case study from Denmark, so thought it to share with you. 26-year woman, gestational age 28 weeks, was referred. The history showed no prodromal symptoms and had only itching. Was diagnosed with gestational diabetes 10 days ago, which was controlled with diet. LFT showed very high alkaline phosphatase, basically cholestatic pattern. Her viral markers and autoimmune markers were negative. She was put on ursodeoxycholic acid and showed improvement in LFT as well as clinically. So she was discharged in a good general condition, but after 18 days came back again with premature labor pains at gestational age 31 weeks. Caesarean section was found due to fetal distress. Let's see what was the surgical finding. Large amount of purulent fluid was found with extensive adhesions, and surgeon noticed metastatic areas in liver and abdominal wall, and there was a large ulcerated mass lesion in sigmoid colon, and biopsies from these areas were sent for pathology. So this was a metastatic carcinoma arising from colon. So a take-home message on this patient is colon cancer at a young age often appears in a more advanced and aggressive stage. Physiological changes that support normal pregnancy, like growth factors, they also promote tumor proliferation. And early diagnosis of colon cancer is difficult during pregnancy. Simple rectal examination is to be done in suspected cases, and evaluation of anemia in such cases is to be done more carefully. It may be helpful to do additional tests such as stool for occult blood. Now in summary, liver disease in pregnancy poses a significant challenge to treating physician and gynecologist. Liver disease may be pre-existing or pregnancy related or coincidental with pregnancy. Apart from pregnancy related jaundice, viral hepatitis is the most common one. Liver injury may be cholestatic or hepatocellular. Plan for treatment involves etiological as well as host factors, and plan of treatment also depends on stage of pregnancy. Thank you.
Hi. Thank you, Dr. Pandey. It was such an excellent presentation. But I want to ask you one question. In the obstetric practice, when obstetrician, what are the points the obstetrician should keep in the mind regarding the liver disorders? Because liver physiology changes tremendously during pregnancy and there are a lot of adaptations. So what you suggest and what you can give some important tips to obstetrician when they what points they should keep in mind and when they should refer the patient to the gastroenterologist or hepatologist?
A very good question, madam. In case any woman presents with history of liver disease in past, or even history of pregnancy related jaundice in past in form of preeclampsia, eclampsia or hyperemesis gravidorum or ICP, there one should do one LFT always. And secondly, as we have seen in the discussion, HbAg screening is mandatory in all pregnancies, and if it is negative, they should be they can be vaccinated also. And clinically, if there is any indication regarding liver disease, then you have to evaluate them extensively.
Sir, regarding hepatitis B positive with pregnancy, suppose this patient that you have LFT normal, CBC normal, no thrombocytopenia, sonography doesn't show chronic liver disease or any type of. So patient first visit in antenatal in the first trimester, but you want to just rule out to prevent the transmission for baby. So at what time you should ask for the DNA?
DNA, very good question. I have shown in the slide. At 24 weeks preferably, we can ask for a DNA level. Because even initially if it is not detectable, during pregnancy being a immunotolerant state, the virus can proliferate during pregnancy. So at 24 weeks it is recommended to do DNA. If it is more than 2 lakhs international units per ml, then you have to put them on antivirals. Preferably tenofovir is the drug of choice because of better safety.
Message is that we should wait for up to 24 to 30 weeks.
Yeah.
And then we ask for, because it is unnecessary to do 2 times DNA within a span of 2 to 3 months.
Yes.
Do we have any questions from the audiences? I have a question, sir. Is it safe to give ursodeoxycholic acid in the first trimester of pregnancy?
Pardon, sir?
Ursodeoxycholic acid in the first trimester of pregnancy. Is it safe to give first trimester?
Ursodeoxycholic, sir, in second and third trimester it is known to be safe because it has been extensively used in cases of ICP, which is more common in second and third trimester.
Sir, I can take that question like in terms of, it's been found to be safe in doses of say up to not more than 2 grams in the first trimester. People have lot of studies which go on to say 500 milligrams BD in the first trimester would be fine. If needed more, then the second and third trimester you may go up to 2 grams. Not any doses beyond 2 grams, I couldn't find literature. So in the first trimester, sir, if it's absolutely indicated, you may, as like rest of everything, like the risks outweighing the benefits, it may be considered. No gross congenital anomalies have been, teratogenicity as such has been reported.
But what are the usual indications in obstetric practice for using UDCA in first trimester?
Sir, if someone is presenting with cholestasis, which usually they do not, I do agree in the first trimester, because per se it is going to, the probability of them presenting beyond the first trimester is high. So rarely do we come across those situations, but if at all needed is the point to be conveyed, it's like fair enough.
Right.
I think that would be if a patient of chronic cholestatic disorder is already on UDLIV or on ursodeoxycholic.
They can be continued on that.
If somebody has PSC or PBC already on ursodeoxycholic acid. So first trimester safety is important to know from that regard. So what she said is perfectly fine, because you would anyway give a dose of at the most 300 TDS.
Right.
So maybe 1200 a day. So we never go beyond that. So 2 gram is anyway a very high dose. And I'm sure that is safe in pregnancy, even in first trimester.
Right.
In spite of giving this dose, sometimes patients, they don't respond, no? 1200 milligram also. So can we raise the dose, or should we give other anti-allergic drugs?
For cholestasis related itching, I don't think increasing the dose of UDCA will be of any help.
Ma'am, in fact, local applications are to be resorted
There
to.
are
And-
other methods.
And early delivery is...
And yes, most of the studies say that you deliver between the 37th to the 38th week, and or maybe earlier if things seem to be
Do
deteriorating.
color Dopplers and see the fetal well-being. Cholestasis is also known to cause some meconium staining of the liquor
Ma'am,
and
it's
fetal distress.
It is documented that it
Yeah.
would cause meconium staining, though that's just one point, but because it is like toxic to the cardiac muscles per se, so Dopplers usually do not reflect an upcoming adverse event. So it's like,
I think sir wants to say something. Please.
sir, please.
Only one comment, Dr. Trivedi,
Sir.
you have said it, giving the beta blockers. On one of the slides you have said it.
Sir.
Cirrhosis liver. I just want to comment, many times what happens, the microemboli from the amniotic fluid goes into the pulmonary area, in the lung, and they induce a bronchial asthma-like symptoms. Sometimes it's a precipitate bronchial asthma-like. And many times when we give the beta blocker, they are still more precipitate. So one has to be very cautious in giving it,
Right.
because this is very important part. Because amniotic fluid microemboli, we are not able to do it, and they precipitate it into a bronchospasm, a very severe bronchospasm. And many times what we see is that whenever a patient with a pregnancy, they come as a bronchial asthma, and we treat it like that. They do not require any treatment, only thing they require low molecular weight heparin at that time, not the bronchodilator or something like that. So one has to be very cautious in giving the beta blocker.
You are right, sir. You have to be cautious. You have to prescribe them only if the varices are very large and they are associated with high risk signs and there are high chances of bleed. Then only we have to use these drugs.
So available data shows maximum dose of UDCA is the 15 mg per kg body weight, not more than this. So this is based on the weight, not like 300, 600, 900 or 1200.
I think we are already running short of time, so time to conclude the session. Thank you very much for the nice